Today, the three-dimensional reconstruction of the maxillary ridge and its relationships to intraoral and extraoral aesthetics. Basically, what we will go over is what are the extraoral and intraoral objectives when I go into surgery. And I think that as our specialty dealing with implants, we should emphasize extraoral aesthetics. What are my guidelines for surgical planning? How do I go about soft tissue management? What did I change because it didn't work? And of course, we will talk about three-dimensional reconstruction. Now, our eye acts like a very sophisticated lens. And we are able to perceive structures on our face when light reflects off those structures. And it's transmitted to the visual cortex. Now, the lower third of the face that is influenced by surgical reconstruction of the anterior ridge, we have an angle of the lip, we have a jaw angle, and we have a neck angle. Those will be determined by the degree of surgical reconstruction. There are also four other structures. They are always lined by fat. They include the cheek highlight, both on the lip, which will be affected by reconstruction, the jaw highlight, and the chin. And you measure the line from the inferior lid to the supertarsal line. In the young face, that line A is always bigger than in the age face. B, which is the distance from your base of the nose to the cupid bow, in a beautiful young face, it's short. It gets longer as the face ages. It also gets older with implants, and we never addressed it. When you look further, the distance B in a beautiful face is always close to 50% of distance C. In age face, it changes. It changes because it changes differently between male and female. It changes also differently between maxilla and mandible, and the mandibular angle, which is measured from the inferior border to sella, is changing for the old. It opened up, and this distance from the nasal spine to the alveolus, in a female, it grows down and turns in. So you have to start thinking how to reconstruct the anterior ridge, and you have to start thinking again where to place the implants. What is the diameter of the implants? The male is different vertically. The mandible rotates slightly as we age, and the growth from nasal spine to the alveolus is horizontal. There are no rotation internally. So this is what you see in simulations. We published that in one of the recent publications of JAMI by Dr. Daftari, Dr. Malati, Rick Sullivan, and myself, and that will affect future positioning of implants and future reconstruction of the anterior maxilla. So to me, it's very clear that surgical reconstruction of the anterior ridge will affect facial, not just intraoral aesthetics. So what is the sequence that I go through? Obviously, a comprehensive aesthetic, occlusal, and restorative analysis. We always go through computerized tomography. Facial analysis is clear and it's much more elaborate. And I create aesthetic stent. The stent is created from a model, so I don't have any guesswork. I know how I'm going to contain the bone. I know the size of the bone. We build it in wax. We're talking, of course, on large defects. We then create it in acrylic, and I know exactly the delineation, the volume, where do I have to bend it, where I have to reshape it. And then we create an aesthetic stent. And the aesthetic stent has nothing to do with your future implant placement. It only has to do with where the bone is supposed to be. We often discuss donor side as far as intraoral and extraoral, so that means volume. But more importantly, in my opinion, is the topography of the defect and what type of bone is needed. To give you an idea of volume, to reconstruct a small defect in the maxilla, you will need about 3 cc of bone. That is not enough. If you need total ridge reconstruction, will take about 15 cc of bone, and here we're going for corticocancellous graft. If you need just a veneer graft, You can take it from the skull, but remember that all our patients undergo osteopenia and osteoporosis, and the thickness of the bone is diminished. What about topography of defect? It's not discussed in our literature, but I don't think that for an audience like that, I have to explain that those two defects are completely different. The one is more or less, it's a huge cyst. It needs about 30 cc of bone, but you basically have 4 walls for vascularity, and it just punched in. The other defect basically is lost the whole premaxilla. It will be a completely different approach surgically. What type of bone? Cortical bone, of course, will be much more stable as far as dimension than cortico-cancellous bone, and it will be much more stable than cancellous bone. Now let's go over the first two. Control tissue expansion is basically an expander that we place it superficial to the bone, place it and inflate it. You inflate it and close the flap. The patient will come back a week later, you have a self-sealing valve, you inflate it in one direction, you get the blanching of the tissue, and you send the patient home. It's atraumatic and it's not painful. You repeat it 4, 5, 6 times until you generate sufficient amount of tissue. Once you have sufficient amount of tissue, you can replace the expander. The more common option, use planting reconstructive surgery. You basically have an anterior advanced flap. The geometry and vectors are established with a section from the mobile element to the immobile element. There are 2 parallel limbs. Remember that when you advance it, you're still going to have to advance it over a large bone graft. Now, the problem that we have is that all our patients eventually will see the soft tissue. They wouldn't care about the bone. And if you just stretch soft tissue, it's similar to stretching a balloon. So you may be successful in covering the graft. Your color matching will be pretty poor. If you look at those 2 balloons, they are similar in physical properties. They have the same surface area, but they have different color. So we have to enhance soft tissue. Now, if you go into an extraoral site, like an iliac crest, of course, you can take the dermis, you do it as a 1 step, harvest it, and then we stretch it and stabilize it over the highest convexity, the area that will move most. If you go intraorally or you're going to stage the procedure, you can first enhance the tissue, make it thicker, and then when you build the tissue, build the bone, that's when you're going to move the flap and split it, like that. So in this case, we went for a stage approach. First, I built up the tissue with a connective tissue graft. The flap is exposed, the area is exposed, and the internal part of the flap that is not thickened is dissected. So we have basically a double pedicle flap. Keep on dissecting it. The internal part of the flap will maintain its thickness. The outside will maintain the closure. So then you measure. It has to reach the edge flap passively, without any tension. So you will not have early exposure, you will not have any dead space, therefore you'll be successful. Now, the internal part of the flap will be sutured to the edge flap, and you complete your advancement. This will give you a much better color match. That's exactly what the patient wants. The prosthodontist would want that, and it will limit shallowing of the vestibule. Now, there are 4 major preparations in the bone reconstruction. The first one, after all, once you remove the bone graft, it's avascular. We keep it in frozen saline, but there is no blood supply. So take or failure will depend on very quick establishment of osmotic circulation. So we expose the flap, expose the area, and we have irregularities, such as your nasal spine. So we just modify it and use any surgical equipment that you have. Make sure that the recipient bed is smooth and homogeneous. Once this is created, I do practice intramural perforation. Anything that will limit optimal placement of implant will be removed. So in this case, we have an incisive foramen, which is very prominent. It will be grafted. If it will be grafted, I have to remove it, remove all soft tissue and smooth it up. And that's exactly what we do. So we often will graft facially, and we will be grafting lingually. Second stage is a sculpturing of the bone graft. It's a free sculpturing. The bone is not detached of its blood supply. We have a rectangular piece of bone that has to fit into a convexity of an anterior ridge. If you need to practice green stick fracture, that's perfectly okay, as long as it fits. If you have some irregular structures, such as the nasal spine, by all means, allow for that, so you do have this very, very intimate fit. Now, how do we stabilize it? We basically have two different directions. One will be the fixation screws, another one will be fixation screws and a rigid mesh, and I'm talking primarily on large ridge reconstruction. Fixation screws work very well. You have to measure the exact length. If they're too long, they will interfere with orofacial movement. There will be early exposure, and you're going to lose some bone. They're going to get loose. So measurement is extremely important. All fixation screws should be countersunk, all of them, so they do not interfere with the flap. If you have two areas that you graft, and unfortunately we do not graft sufficiently lingually, lingual stability is much more difficult to establish, so graft the lingual aspect first, and then follow with the facial. The length is established, and then the fixation screw is placed in the right length. It should be at least 2 or 3 millimeters shorter of the total volume of the bone graft. In some areas that you have to graft horizontally and vertically, you have to make an early decision whether you stabilize first, vertically or horizontally. In my opinion, always go vertically. After all, the bone is narrow facial-lingually, so it'd be much more difficult to stabilize those two vertical fixation screws. The other option is to go with a mesh. Especially when you have particular matter, it's a good way to contain it. It's very rigid. It's going to hold. The problem with a mesh is to remove it later. Mesh is completely encapsulated with fibrous tissue. It's extremely difficult to find those screws and extremely difficult to delineate the initial positioning. And that's exactly what happened to me here. I tried to remove the mesh intact, and I fractured it, and now I have to go and look for the extra piece. So if you use a mesh, underline, before you start removing it, make sure that you have the full circumference of the mesh exposed, because it's so embedded within the soft tissue. We always take approximately 30% more donor material than is needed, so we reshape it, it's approximately 30% more. You can have a 1 unit, and a patient that is relatively young, I will be able to build a facial, build vertically, and bend it like the letter J, and stabilize it with one more fixation screw. It's extremely important to pay attention that all those areas are beveled away from the teeth. It's also beveled smoothly so it does not interfere with the flap, so it doesn't rub on it and doesn't cause early exposure. Now, in some of our older patients, the bone is much thinner, so we'll use multiple units, such as here. We'll create one area, a piece is missing, we'll fit the puzzle. Again, it's completely beveled well away from the teeth. And stabilize it. When you reconstruct it horizontally and vertically that way, you will get the ceramomedal reconstruction as planned. Now, when you reconstruct in 3 dimensions, it's very easy to see how successful or how unsuccessful you are, because if you look at the one and you look at it 6 months later, it becomes very clear that I have no resorption on the first 3 screws on the right, but I have about 2 threads showing on the left side. And that's why we always overgraft. To have too much, it's a blessing. The facial changes are immediate. Remember, the distance B, base of the nose to the lip, is there. The eversion of the lip is there. And that's exactly the extraoral appearance that we want. To look at it on a different patient, Here we reconstructed 14 millimeter horizontally, 8 millimeter vertically. The CT that was done post-surgically illustrates it. It was done with corticocancellous graft and then particular bone as well. When you look at the initial picture of the patient, it's a substantial defect. Post-surgically, 8-9 months later, that's the ridge. Now let's look at the face. Remember, we spoke about facial appearance. This is the preoperative. This is the postoperative. What changed? The volume of the upper lip increased by 60%. The ideal lip height, upper lip height, is 8.5 millimeter in a beautiful face. The angles of the lip increased to 42 degrees. Ideal is 45. So we can reconstruct all this loss of tissue and improve facial appearance just by reconstructing the anterior region, placing implants. Remember those Fabergé eggs? They've changed dramatically. Look at the upper and the lower pre-op and post-op. To summarize, it is my opinion that blood supply is the most critical part for surgical reconstruction. So if you practice atraumatic technique, if you can move flaps over large distances, if you gently in your dissection, if no tension on a flap, you'll be more successful. Surgical skills is absolutely important in developing and achieving the optimal results. And I also believe that any aesthetic outcome without reconstruction would be a major compromise. Thank you very much.